Basics of Medical Biochemistry. First edition, 2024. Chapter 21. Vitamins, Part 2 of 4. By Professor Dr. Muhammad Jawad. MBBS, Pfau, M.Phil Philosophy, Ph.D, Dip M.E. Head of the Biochemistry Department-Fazaia Ruth Pfau Medical College, Air University-PAF Base Faisal-Karachi-Pakistan. Ex-Professor of Biochemistry, Qassim University Kingdom of Saudi Arabia. Ex-Professor, Head of the Biochemistry Department and Vice Principal. Liaquat College of Medicine and Dentistry and Fatima Jinnah Dental College, Karachi, Pakistan. 21.6 Vitamin K. It is a fat-soluble and heat-stable vitamin, also known as an anti-hemorrhagic factor or coagulation factor. Chemically, three forms of vitamin K are found. K1 equals plant origin, phylloquinone or phytonadione, isolated from alfalfa plant. K2 equals bacterial origin, menaquinone. K3 equals synthetic, menadione, is more potent than K1 and K2. On administration, it is converted to K2. It is therefore provitamin K2. It is water-soluble and given, 1 mg intramuscularly, to newborn babies to prevent hemorrhagic disorder. All the vitamin K analogues have a similar structure as they share a quinone ring and an isoprenoid side chain. Vitamin K is the only fat-soluble vitamin that acts as a coenzyme. Figure 21.8 Structure of vitamin K. Sources of vitamin K: animal, fish, milk, meat, egg yolk. Plant, green leafy vegetables, example spinach, alfalfa, cauliflower, cabbage, broccoli, soybeans, etc. Endogenous synthesis, by intestinal bacteria. Absorption, transport, storage, and excretion of vitamin K. Absorption of vitamin K is the same as lipid absorption and other fat-soluble vitamins. It occurs mainly in the jejunum via lymphatics. Bile salts are required for optimal absorption. After absorption, it is transported by chylomicrons to the liver. K3 is directly absorbed in the systemic circulation. A small quantity may be stored in the liver. Regarding excretion, very small via bile or urine. Some amounts are lost through feces. Lactating women may release some amounts of milk. Adequate intake daily, of vitamin K. Infants, 2.0 to 2.5 g. Children, 30 to 55 g. Men, 70 to 120 g. Women, 60 to 90 g. Pregnancy and lactation, 70 to 90 g. Functions of vitamin K. 1. Clotting factors formation. It significantly helps the formation of several clotting factors. The liver, in the presence of vitamin K, forms clotting factors 2, prothrombin, 7, 9 and X. Vitamin K is required for the post-translational gamma carboxylation of precursors of clotting factors 2, 7, 9 and X. It acts as a coenzyme, hydroquinone, for carboxylase in this carboxylation reaction. This reaction results in the conversion of several glutamic acid residues to gamma-carboxyglutamyl or carboxyglutamate residues in these clotting factors. Gamma-carboxyglutamyl residues, negatively charged, bind to the positively charged calcium ions to form prothrombin, calcium complex. The complex binds to membrane phospholipids of damaged tissue and increases the rate of proteolytic conversion of prothrombin to thrombin to ensure proper clotting. 2. Role in electron transport chain, etc. Vitamin K is involved in etc. due to structural similarity with coenzyme Q. 3. Respiratory/photosynthetic mechanism. Vitamin K is regarded as an essential component of the respiratory mechanism in animals and the photosynthetic mechanism in plants. Figure 21.9 Function of vitamin K. Clinical aspect. Analogues of vitamin K, anticoagulant drugs, warfarin and dicumarol, are structural analogues of vitamin K. They inhibit the activation of vitamin K to hydroquinone form. Hence prothrombin and clotting factors are not carboxylated, and as a consequence blood coagulation time increases upon injuries. Deficiency of vitamin K. The main causes are Inadequate intake of vitamin K by the mother during pregnancy and lactation. Congenital absence of bacteria in GIT. Excessive use of broad-spectrum antibiotics. Decreased permeability of placenta for vitamin K during gestation. The main clinical features due to deficiency of vitamin K are: deficiency of physiologically active prothrombin, prolonged prothrombin time, abnormal clotting factors, hemorrhagic status such as newborn may bleed into the adrenal, brain, GIT and from the umbilicus. In adults, bleeding occurs most commonly after the operation of the biliary tract. Toxicity of vitamin K is rare. If occurs, then it can block the action of anticoagulants and may cause hemolysis and kernicterus. 21.7 Vitamin C. It is a water-soluble vitamin also known as ascorbic acid. It is a white crystalline, odorless substance with a sour taste. Its structure resembles monosaccharides. In the human body, found as L-ascorbic acid, D form is inactive. Most species can synthesize their vitamin C from glucose. The human body and certain other animals like guinea pigs, fishes, some bats, and invertebrates are unable to synthesize vitamin C because they lack the key enzyme gluconoloctone oxidase. Vitamin C is a strong reducing agent, readily oxidized to dehydroascorbic acid, which is then converted to oxalic acid through an intermediate metabolite called 2,3-dictogulcanic acid. The acidic property of vitamin C is due to the enolic hydroxyl group. It is absent in dried, preserved, and canned foods. Freezing and dehydration retain vitamin C. Figure 21.10 Structure of vitamin C. Sources of vitamin C. Animal, liver and kidney. Plant, fresh citrus fruits such as lemon, orange, grapefruit, guava, apple, strawberry, etc. Fresh vegetables such as tomato, cauliflower, cabbage, green peas, potatoes, beans, etc. The best food sources of vitamin C are uncooked or raw fruits and vegetables. Absorption, transport, storage, and excretion of vitamin C, being water-soluble, easily absorbed in GIT. It is mainly absorbed from the stomach and small intestine. Vitamin C is heat-labile. In the process of cooking, about 50% of vitamin C is degraded and 20% is oxidized. Oxidation of ascorbic acid is rapid in the presence of copper. Only small amounts, 1 gram, of vitamin C are stored in the body. It is found in the tissues as ascorbic acid and dehydroascorbic acid. Chief storage sites are the retina, adrenal gland, pituitary, and thymus. It is excreted in urine as such as well as in the form of its derivatives. A small amount is also lost through sweat. Recommended dietary allowance, RDA, an adequate intake daily, of vitamin C. Infants, 40-50 mg. Children, 15 to 25 mg. Men, 50 to 90 mg. Women, 45 to 75 mg. Pregnancy, 80 to 85 mg. Lactation, 115 to 120 mg. The recommendations for vitamin C were increased in the year 2000 to 75 mg a day for women and 90 mg for men. As a water-soluble vitamin, approximately 250 mg to 500 mg a day is enough to saturate the body tissues, and consumption of more than 1000 mg per day may lead to diarrhea. The beneficial effect of vitamin C is noted in the treatment of tuberculosis. The clinical dose is 500 mg per day. Vitamin C is recommended for the treatment of ulcers, trauma, and burns. Functions of vitamin C. 1. Formation of intracellular substance. It is required for the activities of fibroblast, osteoclast, and formation of collagen fibers and mucopolysaccharides of connective tissue. It is essential for the maturation and cross-linking of collagen. It promotes the hydroxylation of the proline of collagen by hydroxylase in the presence of ferrous iron. The hydroxylation of proline is essential to form the triple helix of collagen. Similarly, vitamin C is involved in the hydroxylation of the lysine residues present on procollagen. Free lysine is not hydroxylated by the enzyme hydroxylase in the presence of ferrous iron. Ascorbic acid and ferrous iron act as cofactors for the enzyme hydroxylase. Synthesis of proteoglycan also needs vitamin C. 2. Wound healing. It takes an active part in wound healing, by promoting the repair process in the injured connective tissue. In vitamin C deficiency, collagen synthesis is defective and thus results in delayed wound healing. It is administered after most surgeries to enhance wound healing. 3. Growth. Sufficient amounts of vitamin C are required for normal growth and development, especially in children. 4. Bones and teeth. Helps in the deposition of minerals on bones and teeth. 5. Iron absorption and mobilization. It influences the absorption of iron from the gut by reducing Fe3+, ferric, to Fe2+, ferrous. 6. Activation of folic acid. Converts folic acid to tetrahydrofolic acid, THFA. In association with tetrahydrofolic acid, it is involved in the maturation of RBCs. 7. Redox reactions, possibly involved in various redox reactions during metabolism. 8. As coenzyme, acts as a coenzyme for various enzymes, example liver esterase. In tyrosine catabolism, para-hydroxyphenylpyruvate hydroxylase catalyzes the formation of homogenesic acid from para-hydroxyphenylpyruvate. Vitamin C is required for this reaction as a coenzyme. In catecholamine synthesis, dopamine beta oxidase catalyzes the formation of norepinephrine from dopamine. Vitamin C is required for this reaction as a coenzyme. Other reactions in which vitamin C is involved as a coenzyme are biosynthesis of bile acids, formation of heme, synthesis of corticosteroid hormones, formation of carnitine, etc. 9. Processing of hormones. Certain peptide hormones like ADH, oxytocin, and CCK need hydroxylation of glycine, which is carried out by peptidyl glycine hydroxylase, which requires vitamin C. 10. Sparing action of other vitamins. Vitamin C is a strong antioxidant. It spares vitamins A, E and some B complex vitamins from oxidation. 11. Protective function. Vitamin C increases the synthesis of immunoglobulins and increases the phagocytic action of leukocytes. It reduces the risk of cancer, coronary heart disease and cataracts as it is concentrated in the lens of the eye. Regular intake of ascorbic acid reduces the risk of cataract formation. 12. Detoxification. Vitamin C is involved in the detoxification of various poisonous substances such as bacterial toxins. Deficiency of vitamin C. Scurvy. The deficiency of vitamin C results in a disease called scurvy. It occurs when the plasma ascorbic acid level is dropped to less than 0.1 mg/dl, normal equals 0.7-1.2 mg/dl. The main causes of its deficiency are: inadequate intake is mainly caused by dietary deficiency. Impaired absorption, secondary to intestinal diseases. Increased demand for vitamin C in pregnancy, lactation, surgery, and burns. Scurvy is characterized by the following signs and symptoms. 1. Teeth and gums change. Gingivitis, inflammation of the gums, is characterized by swollen and purplish gums with a bad smell, necrotic changes, bleeding tendencies, teeth becoming loose, fragile, and start falling off. 2. Hemorrhagic tendencies. In vitamin C deficiency, collagen is abnormal and the intracellular cement substance is weak, hence, capillaries are fragile, leading to the tendency to bleed even under minor pressure. Various small or large hemorrhagic regions develop anywhere in the body. Bleeding usually occurs from mucous membranes of the mouth, gut, urinary tract, and skin. Petechial hemorrhages and ecchymoses are commonly seen. In severe deficiency, hemorrhage may occur in the conjunctiva and retina. 3. Delayed wound healing. Failure of cells to deposit collagen fibers and intracellular substances results in the delayed healing of wounds. 4. Arrested bone growth. Retardation in the growth of bones. Bones become weak, fragile, and easy to get fractures. The scorbutic rosary is characterized by the sinking of the sternum and elevation at rib margins. 5. Skin changes. Keratoses of hair follicles on the skin, especially in the region of upper arms, back and chin. 6. Nervous changes, incoordination of neuromuscular junctions. 7. Anemia. It may be normochromic, normocytic, due to bleeding, or megaloblastic, due to reduced erythropoiesis, and microcytic hypochromic due to impaired iron absorption and impaired heme synthesis. 8 nonspecific changes: weakness, irritability, anorexia, weight loss, susceptibility to infections, restlessness, etc. 9 infantile scurvy, Barlow's disease. It occurs in infants between 6 to 12 months of age. It can be prevented by a diet supplemented with vitamin C. Toxicity of vitamin C: it is rare as the excess of vitamin C is excreted, and is not accumulated in the body. More than 2000 mg consumption may cause iron overload. 21.8 Vitamin B1, thiamine. It is a water-soluble vitamin also known as thiamine, anurine, anti-beriberi factor, or antineuritic factor. Chemically composed of pyrimidine and thiazole rings joined by a methylene bridge. It is a white crystalline compound not destroyed by heating up to 120 degrees Celsius but slowly destroyed by moist heat. Rapidly destroyed in an alkaline medium. Freezing, canning and dehydration result in a small loss. Figure 21.11 Structure of vitamin B1, thiamine. Sources of vitamin B1. Plant, whole cereals, yeast, whole wheat flour, fresh fruits and vegetables. Animal, egg yolk, liver, kidney, milk, if taken in large quantities, etc. Thiamine can be synthesized by plants and some microorganisms, but not usually by animals. Human beings require thiamine from their diet, however, small amounts may be obtained from synthesis by intestinal bacteria. Absorption, transport, storage, and excretion of vitamin B1. Vitamin B1 present in dietary sources is readily absorbed from the intestine by sodium-dependent active transport process. Absorption is interfered with by the enzyme thiaminase, found in fish and shrimps, tea and coffee. Alcoholism, smoking, prolonged use of antibiotics and serious or prolonged illness also interfere with its absorption. The body can only store up to 30 mg of thiamine in different tissues. It is excreted by the kidney. Recommended dietary allowance, RDA, an adequate intake daily, of vitamin B1. Infants, 0.2 to 0.3 mg. Children, 0.5 to 0.6 mg. Men, 0.9 to 1.2 mg. Women, 0.9 to 1.1 mg. Pregnancy and lactation, 1.4 mg. Functions of vitamin B1. Thiamine has a key role in energy-yielding reactions and the metabolism of carbohydrates. Most of its functions are carried out after being converted to thiamine pyrophosphate. 1. Formation of thiamine pyrophosphate, TPP. TPP is a coenzyme produced from thiamine by the enzyme thiamine diphosphotransferase or TPP synthetase. This reaction needs ADP and Mg2+ ions. TPP is also known as thiamine diphosphate. Thiamine plus ADP, thiamine pyrophosphate plus ADP. Thiamine pyrophosphate acts as an essential cofactor for enzymes that catalyze the oxidative decarboxylation of alpha-keto acid to form an acylated coenzyme A, acyl-CoA. 2. Role of TPP in pyruvate dehydrogenase, PDH, complex. Pyruvate is decarboxylated by the pyruvate dehydrogenase complex to acetyl-CoA. The PDH complex consists of 3 enzymes, pyruvate dehydrogenase or pyruvate decarboxylase, E1, dihydrolipoyl transacetylase, E2, and dihydrolipoyl dehydrogenase, E3. It requires 5 cofactors, CoA, NAD+, lipoic acid or lipamide, TPP, and fat. TPP is the cofactor for E1 of PDH complex. Glucose metabolism is severely impaired in thiamine deficiency, and there is significant and potentially life-threatening lactic and pyruvic acidosis. 3. Role of TPP in alpha-ketoglutarate dehydrogenase complex. This enzyme catalyzes the conversion of alpha-ketoglutarate to succinyl-CoA by decarboxylation. TPP is required as a coenzyme for this reaction along with lipoic acid, NAD+, fat and CoA. 4. Role of TPP in branched-chain alpha-keto acid dehydrogenase complex. TPP is required as a coenzyme for the oxidative decarboxylation of all three branched-chain amino acids, leucine, isoleucine, and valine, catalyzed by mitochondrial branched-chain alpha-keto acid dehydrogenase complex. 5. Role of TPP in transketolase reactions. TPP is an important cofactor, along with Mg2+, for the transketolase reactions in the pentose phosphate pathway, HMP shunt, of carbohydrate metabolism. 6. Role of thiamine and TPP in nerve conduction. TPP has a role in nerve conduction. It phosphorylates and then activates the chloride channel in the nerve membrane. Thiamine seems to have a role in axonal conduction, particularly in acetylcholinergic and serotoninergic neurons. Deficiency of vitamin B1, thiamine, beriberi. The deficiency of thiamine causes a disorder known as beriberi, means equals I cannot, that reflects the severity of weakness and state of paralysis. In this disorder, the utilization of carbohydrates is severely impaired, leading to the accumulation of pyruvic and lactic acids in the blood. Causes of thiamine deficiency. Eating food having a high content of thiaminase, including milled rice, raw freshwater fish, raw shellfish, and ferns. Excessive consumption of tea, coffee, and betel nuts. Use of processed food with content high in sulfite, which destroys thiamine. Alcoholism and smoking. Conditions in which demand is increased, such as pregnancy, lactation, hyperthyroidism, fever, severe infection, and exercise. Conditions causing its loss, such as diarrhea, diuretic therapies, peritoneal dialysis, hemodialysis, and hyperemesis gravidarum, extreme, persistent nausea and vomiting during pregnancy. Decreased absorption due to chronic intestinal disease, gastric bypass surgery, malabsorption syndrome, etc. Metabolic consequences of thiamine deficiency. Decreased efficiency of all the enzymes for which TPP is required as a cofactor. The rate of conversion of pyruvate to acetyl-CoA and the use of acetyl-CoA through the TCA cycle is depressed. The formation of the reduced electron carrier, NADH plus H plus, and the ADP produced from it via oxidative phosphorylation is also decreased. The working of the heart and nervous tissue are affected early as they need ADP at a high rate. Decreased production of NADPH and decreased conversion of glucose to pentose, such as ribose. It may also cause decreased regeneration of reduced glutathione and susceptibility to oxidative stress. Lactic acidosis occurs. Pathological consequences of thiamine deficiency. Degeneration of peripheral nerves, thalamus, mammillary bodies, and cerebellum. Severe reduction in cerebral blood flow. Vascular resistance increased. The heart may be dilated, high output heart failure may occur. Swollen muscle fibers may be fragmented and vacuolized with interstitial spaces filled with fluid. Edema in the feet and legs due to vasodilation. Types of beriberi. 1. Dry beriberi. It is also known as neuritic beriberi. It is characterized by the involvement of the nervous system. It is more common in adults, and the neurologic findings can be peripheral neuropathy characterized by symmetric impairment of sensory, motor and reflex functions of the extremities. These deficits are bilateral and roughly symmetric, occurring in a stocking glove pattern. Other symptoms are tenderness of skin and deep structures, cramps, atrophy, and weakness of muscles, difficulty in rising from a squatting position, loss of deep reflexes, incoordination of movements. Foot drops, toe drops, and wrist drops are common. Insomnia, mental tension, and vertigo. Paresthesia and anesthesia in limbs are common. 2. Wet, cardiovascular, beriberi. Wet beriberi is a thiamine deficiency that involves the cardiovascular system. There is impaired energy metabolism in the myocardium. Initial symptoms include vasodilatation, chest pain, tachycardia, a wide pulse pressure, sweating, warm skin, and lactic acidosis. Late symptoms include heart failure, causing orthopnea, and pulmonary and peripheral edema. Vasodilation may become severe and sometimes results in shock. 3. Infantile beriberi. It occurs in infants of age 3 to 4 weeks, who are breastfed but mothers are already suffering from thiamine deficiency. Aphonia, loss of voice, and absent deep tendon reflexes are characteristic features. Sudden heart failure may occur. 4. Shoshin beriberi, it is the form of wet beriberi in which deterioration occurs rapidly, also termed acute fulminant cardiovascular beriberi or Shoshin beriberi. The leading injury is to the heart and rapid damage follows the inability of the heart muscle to satisfy the body's requirements because of its injury. Edema may not be present. The main features are cyanosis of the hands and feet, tachycardia, swollen neck veins, agitation and nervousness. 5. Wernicke-Korsakoff syndrome. Wernicke encephalopathy is a neurological disease characterized by the clinical triad of confusion, the inability to coordinate voluntary movement, ataxia, and ocular abnormalities. If untreated, coma and death may occur. Korsakoff syndrome is a chronic memory disorder caused by a severe deficiency of thiamine. Korsakoff syndrome most commonly occurs in alcoholics who do not consume foods fortified with thiamine. Both Wernicke's encephalopathy and Korsakoff's psychosis can occur simultaneously. Therapeutic uses of thiamine. It is specifically used to treat thiamine deficiency. It is also used to treat digestive problems like anorexia, ulcerative colitis, and diarrhea. It can be used for boosting the immune system, relieving diabetic pain, heart disease, alcoholism, aging, vision problems such as cataracts and glaucoma, and improving stamina in sports persons. 21.9 Vitamin B2, riboflavin. Riboflavin or vitamin B2 is a member of the vitamin B complex family and is also a water-soluble vitamin. It is an orange-yellow crystalline compound that contains diribitol and the heterocyclic substance flavin. It is heat-stable in neutral and acidic mediums but heat-sensitive in alkaline mediums. It is found in the phosphorylated form in living cells. Figure 21.12 Structure of vitamin B2. Sources of vitamin B2. It is widely distributed in nature, as it is found in milk, dairy products, organ meats, liver, kidney, and heart, enriched bread, eggs, green leafy vegetables and nuts. Ultraviolet lights, such as sunlight, destroy riboflavin, and that is why milk is packed in opaque plastic or cardboard containers. Grains and cereals are fortified with riboflavin in many countries. Absorption, transport, storage, and excretion of vitamin B2. It is readily absorbed from the upper part of gut. There is no significant storage of riboflavin. Only a small amount of riboflavin is stored in the liver, heart, and kidneys. When excess amounts are consumed, they are either not absorbed or the overabsorbed amount is excreted in urine. Recommended dietary allowance, RDA, an adequate intake daily, of vitamin B2. Infants, 0.3-0.4 mg. Children, 0.5 to 0.6 mg. Men, 0.9 to 1.3 mg. Women, 0.9 to 1.1 mg. Pregnancy and lactation, 1.4 to 1.6 mg. Functions of vitamin B2. The most important biologically active forms of vitamin B2 are flavin adenine dinucleotide, FAD, and flavin mononucleotide, FMN. They participate in a range of redox reactions, some of which are crucial to the function of aerobic cells. FMN and FAD are produced by the successive reaction of riboflavin with ADP. FMN is formed first by the action of riboflavin kinase on riboflavin. FMN is then converted to FAD by the action of FAD pyrophosphorylase with ADP. FMN plus ADP FAD plus PPI. FMN is one of the components of complex I of the electron transport chain, while FAD is involved in the activity of complex II. FAD acts as an electron carrier and takes part in both the TCA cycle and oxidative phosphorylation. It accepts electrons and is transformed into FADH2. Deficiency of vitamin B2. There is no specific disease caused by a deficiency of riboflavin, however, it may be termed as a riboflavinosis. Primary riboflavin deficiency occurs when the diet is poor in vitamin B2. Secondary riboflavin deficiency occurs for another reason, maybe because the intestines cannot absorb the vitamin properly, or the body cannot use it, or it is being excreted too much. The main deficiency symptoms are mouth lesions involving the tongue, glottis, and pharynx, weakness, lassitude, and drowsiness, redness and shiny appearance of lips, chylosis, lesions at the angles of the mouth, tongue shows inflammation, magenta-colored tongue, angular stomatitis, painful fissures at the angles of lips, dermatitis, skin becomes scaly, greasy, and inelastic. Neuropathy may also occur in some cases. Riboflavin deficiency should be suspected if characteristic signs develop in a patient with other B vitamin deficiencies. Diagnosis of riboflavin deficiency can be confirmed by a therapeutic trial or laboratory testing, usually by measuring the urinary excretion of riboflavin. It is interesting to note that despite popular belief, a deficiency in riboflavin does not lead to hair loss. End of Part 2 of 4 of Chapter 21. Thank you.